1/3 of the 5-year survival rate of those patients without lymph node involvement, thoracic lymph node. And if you look at here this curve for colorectal cancer, 388 patients included. If they were thoracically M0, they have a significantly higher 5-year survival rate, so that is very impressive. Or if you look at several studies with colorectal cancer, here you have the incidence, and the incidence of lymph node involvement in colorectal cancer was between 10 and 20%, but the prognostic significance was shown in 5 out of those 6 publications. And in the international registry, it was not looked at. And here you can see the prognostic impact in sarcoma patients, not quite as big in the number of cases, but you have 33 patients, and here a prognostic factor was mediastinal lymph node involvement, especially in younger patients in this case. You have kidney cell carcinoma. I told you those make about 30% of my patients, and here again the frequency of lymph node involvement is higher than in colorectal cancer. Up to 40% of the patients with kidney cell carcinoma developed surgeons with their feet. They do treat recurrent disease. We do treat synchronous disease, and of course multiple and bilateral. And this is conclusion for the first part. Patients with pulmonary metastases need to be evaluated for potential resection. I think that is very important. This should be interdisciplinary, and it helps if the oncologist sees the same rationale. Metastasis must be completely resected, and that is from the beginning. If you have a 2 millimeter central nodule in a lobe where you don't think you can get it, you should not try it. You have to reach everything you see. Utilizing a laser is nice to have in this setting, but most of the work is before. Which patient might profit and which patient might not. But if you come to the point where you say metastasectomy is the thing, the laser is good. You can reduce the rate of lobectomy. Patient has more functional reserve. And you can resect a higher number of metastases. So I want to conclude with a little tidbit from our newspaper. At that point, we introduced the new laser, Limax 120 in Löwenstein, and the newspaper took that up for an article. We have never used it for lung cancer, so the whole article was nonsense. They wrote what they thought might be interesting, but the effect was that within a week, 20 patients showed up because everyone loves the laser. Star Trek, Battlestar Galactica, laser is always great, and patients just love the laser. Have to.
We have a discussion session with Prof. Is okay?
Yeah.
In the first term, we have 3 questions. Is there any question from the audience? Okay.
Necessary to do like a frozen section?
That's a very good question. The presentations today, the how to do it part will follow, but I will come to your question because it really depends on the kind of what you use. We don't do frozen sections because micrometastasis, it's hard. If you have a nodule like this, the whole site can have micrometastasis. So the pathologist really has difficulties in looking at every place. Usually we have a margin of 1 centimeter, with the laser a little less, and why that is, so I will show you on a slide later. But 1 centimeter usually is enough. For example, whether you and then we see reasons. If I do, we always do sequential metastasectomy. So if you start at the right and you're positive, you have to really think whether you do the other side. It's never years, 2 metastases and 3. Okay, and how much you can. That has never left me over the last 10 years. The CT, that's why I digress here. Sorry. PET-CT in Germany is allowed by insurance companies for non-small cell lung cancer, but nothing else. Okay, that's okay. Thank you. So the PET-CT works very well with colorectal cancer, and in those patients that pay it themselves, you can use it for staging purposes. It has a very low false negative rate, and you see metastases very nicely if they're a size 5 millimeters or bigger here from this study. So yes, PET-CT works nicely in some. Now, this is how pulmonary metastases frequently present. They are subpleural, they are asymptomatic, and usually found by chance or by vigorously staging the patient. And the types of surgery are clear to you too. You can enucleate those. You can do wedge resection, segment, anatomic, lobectomy, or pulmonectomy. And there are a lot of ways to do this. You can enucleate and suture over it. You can use a stapler. You can use electrocautery, ultrasound dissection, laser, or you combine any of that. So I think the most important thing is that you advise your patient whether it makes sense to do metastasectomy or not, and that you perform it if it's possible. But I will show you how the laser might help you in this. Now, the classical way of a wedge resection is this. You have the metastasis on the left, you have the stapler, and you take away a lot of tissue too. And you're very close to the tumor here. And this is from the hollow work too. If you do it like this, if you do a wedge resection, your amount of healthy tissue that you take away is 7-fold higher than if you do a laser resection. That is, if you only take this nodule out, it preserves a lot of lung function. And here's the question with the margins. You have, when you have a zone where the laser works, where the tissue vaporizes. It makes a lot of smoke. Then you have about a 5 millimeter zone on both sides where you have necrosis. So if you stay close to the tumor, there's always a 5 millimeter zone on the other side where all cells die, whether good or bad. And then you have a hyperemia zone. That does not really matter because their tumor cells will survive. But for a pathologist, this is very difficult to interpret. The first year was awful with our pathologists. We always got resection rate, resection margin incomplete. He would never want to say it's complete or not. So, but clinically, out of those 334 patients, only one had local recurrency in 3 years. So the local recurrency rate not depending on the type of tumor, is very low. So the advantages of the laser are parenchyma preservation, little collateral damage, we'll come to that, good hemostasis, little air leak, possibility for redo surgery is easier, I think, and quality of life, pulmonary function is similar to before the operation, so that is a good point. My most spectacular patient was a young man with a chondrosarcoma who had 56 metastases on each side at the time of presentation. He had a chemotherapy to begin with, and he reacted very good to the chemotherapy. So we decided that in spite of that many metastases to operate, we resected all metastases, even probably a couple more. And after a year, he presented again with 7 and 8 metastases. But he was 18 years old at the time. And so we did a redo on both sides. He again had chemotherapy. And today, this is 5 years ago, he plays soccer again. You will not cure everyone. That is one mouse, basically. But it's very impressive how things can work, and that he can still breathe and play sports. So keep that in mind. That is possible with a laser. But it's very tedious work. It takes a lot of, if you do 56, my patience is usually used up after 5 or 6. But it takes a lot of experience, and I like this cartoon of the misplaced thoracic drain. I thought you do this on a daily basis, it says there in Germany. So whatever you do a lot, you usually get good at, and stay with it. Out of airplane flying, they have a saying in the US Air Force, proper planning prevents piss-poor performance. The 6 Ps, and the same is, I think, important for surgery. You have to plan everything ahead, type of thoracotomy, once the thorax open, inspection, and help patients see are the metastases there where we thought they would be. Is my operative strategy still valid? And then do the resection. And in North America, median sternotomy is the choice of approach. And I completely disagree. What we do is we do a sequential lateral thoracotomy. Very little muscle is actually in your way, so you don't do a lot of damage. You go anterolateral, you do one side, patients tolerate that very well. You get to every point in the thorax very easily. You can do a lymphadenectomy under vision. Works very nicely. After 6 weeks, we have the patient again for another CT scan, and if things are stable, we do the other side. I've had, let's say, my wilder days. I did this at one time, but patients did not tolerate that very well. A lot of pain. They had problems getting out on their feet again. So sequentially, actually, it works very nicely. The median sternotomy is well tolerated. That is not the problem. But lymphadenectomy is a pain if you have to go around to the back. And also the dorsal parts of the lower lobe, especially on the left, are difficult to reach. And that's why we don't really do it that way. And this is why we always used to do this open. I will show you a video later where we do a VATS metastasectomy. So we've changed our approach, but we used to find a lot of unexpected nodes while feeling the lung. So the first step after thoracotomy is always you feel every part, and I usually let my resident feel too, because of course his motivation is to find things that I did not find. And with that, the rate is always very good. What I like to do is I print out the CT scans with the metastases. So I know we have a laser meeting in Löwenstein every year where we do some of those presentations. We have other presentations too. There's an oncologist there. But one is also on laser safety. And two things you have to keep in mind. Never put the laser point at someone else, because the only thing that really can get hurt is your eye. You laugh, but I know a lot of surgeons who point at others with the instruments. So this is an absolute no-no. Never put the laser or point the laser at someone. And the other is to put it to rest while you're not working, so it does not accidentally start. Other than that, it works by heat, and you have to. I talk too much. Let me see. Let's restart this one. And you have to protect. And you have to protect the surroundings a little. I've never seen a problem, but what we do is we put sponges or gas around. You can sometimes, if you look at the lincula here, you can go through it if things don't work as you wanted, and then you might overheat the tissue behind it. Now, if you very easily when using the laser. Now here we use a lot of power. That's why it goes so fast. I usually like it a little slower, because then you see the lung tissue really go away nicely. And the second you get too close to the tumor tissue, you see the difference and you can readjust. But this was okay. You work around, you can do this by a quarter too. But the resection zone usually is air dry and blood dry this way. And so this works very nicely. And I think if things work out, you can have a chance that are just a millimeter of size or so. You can just vaporize them. Hit them quick. Backside is you don't have a histology of those then. If you want central metastases like this can lead to a lobectomy, but with a laser you can also enucleate them. And what is really important, we started out with a 40-watt laser, and that thing was slow. You saw the vessel and went boom, and everything was bleeding, and we had that for the next hour. And then we learned to go slower with deeper metastases. So when you're in the periphery, you can use 80 watts easily, and it goes very quickly, it works nicely. You can even use 120. When you're close to central vessels, go slow, go to 40, go to 50 watts, and give yourself the time, but you can preserve the load then. And sometimes it can also be prudent to combine different methods. Go out of focus with the laser, and if the bleeding is not too strong, that works. You can also use forceps, grab the bleeding, and hit the forceps. Sometimes, now in MATS surgery, I don't close the defects. If it's open, I've also seen that after 2 or 3 days, the necrosis dissolves. And all of a sudden you have an air leak after 2 days. Manually feeling palpating the lung. We changed that a little. We are just now gaining experience with VATS procedures and laser. It works very nicely. What we do then is that we do our CT scans in 1 millimeter slices. And if there are small nodules that you will not get on VATS, we do an open procedure. If there's really just 1 or 2 or 3 subpleural nodules that are easily to get by laser, and there is no question of smaller nodes on 1 millimeter CT scans, then we go for VATS. We do this similar to a VATS lobectomy. From the procedure, we have 2 two ports. We usually look from the dorsal port, and we have an accessory thoracotomy with a plastic cover of the thoracotomy. We do not spread. And this is a video which is not done by me, but it is very good. It's from Birmingham, from a colleague. Sometimes difficult is the precise location of the metastasis. In this case, you can see it, and they put a pulse-through suture under it to pull it out. That makes it a little easier. I found it helpful if you only have one metastasis, do the additional thoracotomy right over it. But here now you see the metastasis nicely, it comes out a little, and it's easier to work under it. Right in the interlobium, works very nicely. Now you see the fiber. And here again, you have to keep a little distance. If you touch lung tissue while using the laser, tissue will stick to the fiber, and if you have too much power that you use, it will burn up, and you will have to shorten the fiber every 1 or 2 minutes. So I found 60 watts too much for the endoscopical laser. I usually work there with 40, but here you see how they work around it, how they try to keep their distance. And if you're used to open surgery, consider that the factor of looking at it is a lot bigger here. Now, if you have problems locating it, you can. What we like to do is also put a spiral in it via CT scan or a harpoon. Now, what they do is you also see the smoke. The smoke is a little unnerving at first, so we usually put the sucker in two, and with an accessory thoracotomy, this works nicely. You have to keep the right distance, and sometimes you see it moving. If you're in the left lower lobe, and sometimes with the heart under, it can be even more. It looks like your hand is shaking while working. But you have to keep a little distance in order to not burn or get tissue on the front of your fiber. Now they close the defect. In endoscopical metastasectomy, I don't do that. I do take lymph nodes. I usually try to get 7, I try to get 4 and 2 on the right side, or 5 and 7 on the left. Maybe a 10, maybe a 9 if I find any. I put in 1 drain if I only have 1 or 2 metastases. It usually works nicely. And drain comes out after 2 or 3 days, if no early, and less than 200 cc's of drainage. Patient goes home after average of 6 days postoperatively. They probably could go earlier, but I like to have them completely mobilized, free of pain before they go home. Now this, he does a paravertebral block. We usually use a peridural catheter, don't do a paravertebral block. Now lymphadenectomy we've already discussed extensively, so I will not get back into it. This is just a slide for reminding me. Cost of stapler. In Germany, 1 stapler case costs about €150, depending a little more or a little less if you use an open or a Watt stapler. And the cost cost can really eat up the benefit. I don't know how much it is here, but if you do if you use 3 butt stapler cases, you're almost at 500 euro. And if you consider that we do, well, we do more, but if you do 2 cases of that a week, 50 weeks a year, you're at 50,000 euro. And with a laser, you can save that money. I don't know, the only thing we really have to do new is the coverage of the laser cable, right? All the rest is reusable. So after a while, the laser really helps you save costs. And consider we have about 4 cases a week. And the alternative, if you do once, would be stapler usually. So laser can pay itself off. And now this anesthetist uses the cautery for heating his coffee. I think the laser has at least the same potential for establishing itself in the medical business. So thank you for your attention.
Yeah, the discussion session. Please. Good.
I would like to ask about the closure technique. Do you have any experience in closure the defect using glue or other brand, like for instance, like other coagulation factors to close the defects besides suturing it? That's my first question. And my second question is, do you have any experience in performing the laser technique in the intrabronchial tumor? Because we have several experience for intrabronchial tumor. I know it's not a metastasis, but it's also important. This kind of device, I think, is important. I think that's all. Thank you.
Thank you very much. Those questions are good, and let me start with the endobronchial tumor. That's like almost a reminder to me. It works nicely. We use it for clearing tracheal stenosis. If it's like of a web in the trachea, you can very nicely work with it. Use low power, and also for removing carcinoids or tracheal tumors, it works very nicely. So that is possible. Now with the closing techniques, I think if you use fibrin glue, that's expensive and probably even less effective than the laser. I would say with the leaving it like it, 90%, 95% of those metastases will remain airtight. So you don't really have to do it. But ever so often you will see a patient developing air leak after 2 or 3 days. So we just suture it, but gluing is expensive. We don't even have fibrin glue in our refrigerator anymore, because I don't even, if it bleeds, you have to find a solution for the bleeding. And fibrin glue usually will not be a solution. You have to suture or do something else. Air leak doesn't work. For generating adhesions in pneumothorax, you have different methods. And I'm not really afraid.
Okay. Is there any response from the professor answer? No? Okay. Next question.
Thank you. I'm just wondering, do you always have to resect the nodule? Could you just burn the smaller nodule if you find like diffuse or multiple nodules in the lungs? Can you just burn it with the laser, since it's also killed the
you.
Embolization process, where it goes up in smoke. If you don't need the histology, like you said that you already proved that there were multiple metastases, yes, you can do that. It's very effective, and the pathologist has less to do.
Okay. And we have two door prize from the PT Atra. If you can answer my question, please raise your hand. The first question is, what is the name of the product that we talked about today?
Limax.
Please applause. Okay, and the second question, what is the safety margin of the laser? The safety margin of the laser?
Can I raise my hand?
Okay.
Taking the whole presentation a little further, because also in colorectal cancer, we talk about oligometastatic patients. We're not talking about those that have tumor everywhere. And if you look at these survival curves going around 2%, and looking at those, you already saw those with pulmonary nodules had a different curve. We found out that some of those patients have a completely different course. If you are those metastases confirmed to only one organ, or can I have an adrenal metastasis and a single lung metastasis? Synchrone versus metachrome interval, disease-free interval is the word. So you find the whole things that we talked before, you find again in this discussions. And the number of metastases is not defined either. Some will say a singular metastasis only makes sense. Others will go up to 5 or 7. But the subject has been around since 1995 in a publication by Hellman. And this you saw, the International Registry of Lung Metastases, and you will see that the same is true for patients with non-small cell. Here you see a work where they looked at does the primary tumor has also to be treated. Because what we're looking at now is not metastasis developing in the long term, but patients presenting with their lung tumor and metastasis. And here they compared resection and or radiochemotherapy or not doing anything. And those patients that were treated locally in the thorax fared better than those where the primary tumor was left alone. Complete resection after survival after complete resection of pulmonary metastasis. 5-year survival, 44.7%. If metastases were not resected completely, it was 20%. So these are again the same numbers as we saw for the pulmonary metastasis, but now we're talking about adrenal, brain, lung, liver metastasis, bone metastasis. So again, we're talking about small surgical publications, and here they tried to do a review of 51 publications for patients with bone, liver, or kidney or spleen metastasis, and they've only found in these 51 publications, they found 62 patients where this was applicable, and visceral metastases were present in 39. Now, 5-year survival after visceral metastasis was 39%. Non-visceral metastasis, 5-year survival was 63%. So non-visceral metastasis fared slightly better. In Germany, at least, a lot of patients present with adrenal metastasis. And here, a meta-analysis over 114 patients showed that patients with synchrone adrenal metastasis at time of presentation fare not as good, but still. And 5-year survival here after resection of adrenal metastasis and the lung tumor resulted in 25% 5-year survival. Pulmonary metastasis, this slide you saw earlier, fare very well. So if someone has a lung carcinoma plus a single metastasis, resect both and you will result in 5-year survival rates of over 40%. So pulmonary metastasis fare better than other NSCLC metastasis in other organs. Brain metastases are the most frequent, and the number of brain metastases plays a role. The treatment of the metastasis is optional. By guidelines, radiation can be curative. It has to be curative in order to proceed with the primary tumor, but resection can also be an alternative. But the number of metastases plays a role. Prognosis is better if you have less metastases. Now, consider this. You have a tumor in the lung, you have lymph nodes in the mediastinum, and you have distant metastasis. And one of the prognostic factors are the mediastinal lymph nodes. If you have N0 or N1 disease, meaning only local lymph nodes are diseased, prognosis is the upper curve with 5 years of over 60% survival. If N2 or N3 lymph nodes exist, prognosis goes down considerably. In this case, out of 62 patients, none survived 5 years. So this is a really dramatic factor. And the question arises quite frequently in our tumor board, what to do. You have a tumor resectable, you have N2 lymph nodes, and you have 1 or 2 metastases. Would you progress in those patients and operate? Or would you rather go to conservative palliative chemo radiation treatment? But lymph nodes are prognostically significant, and this is another publication out of the year 2014 that shows this. It's not quite as dramatical, but still prognosis is halved if lymph nodes are there, and it shows the degree of systemic disease. Now, several publications address the subject as what to do with a primary tumor. Here, 1,793 patients were evaluated out of 49 publications. Most of them had less than 3 metastases. 7 studies included 5 metastases. Age was 52 to 69 degrees. And a lot of these patients had their metastasis after treatment of the primary. But in 2/3 of those patients, metastases were in the brain. And if you look at the prognostic impact of several studies, the control of the primary tumor was significant in 7 out of 13 of those studies. So doing something for the primary is important if you want to preserve a curative approach for the patient. A lymph node disease was important in 6 out of 12 studies. And if you look down here, only 1 out of 8 studies showed that the use of chemotherapy in this setting had a prognostic impact. But the type of resection showed that pneumonectomy fared a lot worse than lobectomy. So again, preserving lung tissue helps create a better survival rate. And if you have a central tumor, in this case where only clinical studies and 5-year survival rates, they are all around 25%. If you look at radiation of the primary, 5-year survival 7.6%, and that's the same as if you don't have metastasis and you use radiation. A lot of times, after 2 or 3 years, the tumor comes back. You have a local recurrency. So surgery is more effective in treating the primary tumor. It depends on the general condition of the patient and the oncological reasoning which method you use. If a patient has a poor general condition, if I have a very aggressive tumor with N2 or N3 disease needing a pulmonectomy, I would rather go for radiation and take lesser of risk. But if I have a chance to win, to really get everything out, use resection, use surgery. In this study, 61 patients were looked at, and they looked for predictors of overall survival, long-term survival. And here, the resection of the primary tumor was one of the only predictors that was statistically significant. And this also showed in studies by Flannery and Young, but they even had less patients in it. So, but altogether, those studies looking at prognostic factors usually show that surgery of the primary tumor in the thorax has a beneficial aspect on prognosis. Now, there are 2 meta-analyses concerning this subject. Both are out of the London group from Ashworth. One 775 patients, so actually this is the second, the first you already saw. And here, out of 67 publications, 775 patients were evaluated where they had the base data of each patient, but that was retrospective again. And they looked at factors concerning long-term survival. And they compared radiation plus minus chemo versus surgery of the thoracic tumor. And it came out that surgery was prognostically better than radiation and chemo. It's retrospective, but the case load was high. So yes, if possible, if a complete resection is possible, surgery is better. Other factors, very important in deciding who to operate: lymph node status, brain metastases have a better prognosis than most of the others, and adenocarcinomas have a better prognosis. And again, the Tom Treasure group is skeptical whether metastasectomy or resection of metastasis really makes sense. I think retrospectively, yes. In this case, they said, well, the tumor grading is important. Maybe you just select the right patients. Yes, I think that is the case. You have to select the right patients to have good results. And you cannot help everyone with metastasis. But if you pick the right patients, you will have better results than chemotherapy alone. And this, I think, also comes out in newer guidelines. These were from 2007. They're not as aggressive yet as I would like them to be. But here it says isolated brain metastasis should be resected or radiated. And the thoracic tumor should be treated too by surgery. And the same goes for isolated adrenal metastasis. Here they should be resected, and the thoracic tumor too. So the guidelines go into that, but they're not quite as far or aggressive as we are clinically right now. And sounds similar as those patients with pulmonary metastasis, the conclusion, doesn't it? Patients with oligometastatic non-small cell lung cancer, resection of the primary tumor should be considered. Long-term results are considerably better in patients without mediastinal lymph node disease. And due to higher morbidity and mortality, pneumonectomy should be avoided. But in my opinion, pneumonectomy should always be avoided if possible, either by using sleeve resection, by using induction chemotherapy, or induction and radiation. So that goes for all the tumors. And now I thank you for the attention, and it was fun.
Okay, the last discussion session from Prof. Brother. Is there any question for this session? Okay.
Thank you for a very nice presentation. So I think instead of a pulmonary trial, there are no other RCT regarding this metastasectomy. So the evidence is still very low. So I think if you have concluded some kind of benefit or patient criteria which is better it would be beneficial for the patient. Have you considered any criteria for the patient? I mean patient selection in terms of patient selection for this metastasectomy, especially for the laser metastasectomy, because it's still in doubt in cardiothoracic surgery.
I think you pointed out the most important part of all, patient selection. And first of all, I think functional resectability. Do I have an 80-year-old patient with 10 different diseases, heart failure, kidney failure, diabetic? No, leave it alone. The patient has to have a low risk for surgery functionally. For me, that is important. The tumor has to be resectable. So if I have very little nodules where I think I cannot get them surgically, I cannot feel them, and I have 10 of those centrally, it does not make sense. If I have a tumor dynamic where the where the nodules grow in number, I don't mind if the nodules grow fast. But if I have 5 nodules in the first CT and 10 nodules in the second CT, that is a complete no-go, because you will operate and then 6 weeks later you have another 5 nodules. So it doesn't make sense. Slow tumor dynamic, a resectable, a possible complete resection is important, and low risk for surgery. And then I think it makes sense. And then I tell my patients that they have a 40% chance, plus minus a little, of getting rid of the tumor, but they also have a 60% chance of it coming back. They know that. And they are part of the decision. But most of them, they beg for something. They really want there, but there's high pressure. Nobody wants to have palliative chemotherapy. So it's actually up to you to slow them down if things are not okay. And it's difficult. What would you do if you have a 35-year-old patient who is really fit, but he has 5 melanoma metastases and 1 lymph node? His prognosis is 10%, 5 years. Would you say no? It's difficult. And he says, please do something. It's my only chance. If I go for a chemotherapy alone, my chance is 0. So what do you do now? What do you do for yourself? Would you go for a 10% chance statistically, or would you not? It's very difficult. It's easier if you have a singular colorectal metastasis. I think you can even operate on an 80-year-old patient with high morbidity. They usually survive very well. They recuperate. A single metastasis is easy. It's the prognostically poor situations where it really becomes difficult. Did that answer the question?
Thank you, sir. I want to ask about how important about the tumor dynamic, as you said before. Because in our place, the diagnostic tools not very good. Perhaps, do you always treat your patient the first he or she bring the CT, and you ask her or him to wait 3 months later and you evaluate, or you just can operate at the first time? My second question is, if you had patient with one primary tumor in one side, hemithorax in one lung, and one metastasis in contralateral, do you prefer the both? You operate the both side, or you do one by one resection and patient go home and one another? And which one do you prefer, the mother or the son or the child?
That's a very good question. We do this sequentially, and it really depends on the type of operation you need for the primary. If you might need a pneumonectomy, if you might need one, we try to avoid it, but sometimes you cannot really be sure. We would go for the metastasis first, also to see the extent of metastasis. Was there anything we did not see on the CT scan? So if or in bilateral metastasis of colorectal, I usually try to go for the more difficult side first, with the reasoning that if I don't get everything out there, if I leave some tumor behind, I don't have to operate the second side, because prognostically it doesn't make sense anymore. So in this case I would go for the more difficult one. But if I have a potential pneumonectomy on one side, I would operate the other one first to be done with and have less risk for the next operation. Now, yes, indeed, we always wait for 6 or 12 weeks before we operate to see the tumor biologist. And I think that is important, because once a year I pick out a patient like the one I shown you, where within 6 weeks you have explosion of tumor cells. And that's also part of patient selection, what he says. Okay.
Okay. Any other question? Okay.
Do you have an experience in managing the tumor with existing tuberculosis?
Say that again, the last one.
Do you have any experience to manage the metastatic tumor with the tuberculosis?
We are very fortunate in Germany that we have very little experience with tuberculosis. In my team, I have a surgeon from Russia who had 10 years. He worked in a tuberculosis center there for 10 years. So we do have one surgeon who is very experienced in it. But are you asking whether simultaneous active tuberculosis or residual pleural infections and residual? Well, if you have more than one nodule, or we usually try to get histology from one nodule before, because if it's lung cancer, you have to plan different types of operation. We usually go anatomic, like segment lobectomy. So at least from one nodule, we like to have a histology. And then it doesn't really matter. If there's a tuberculoma to go with, we will take it out too, just to be on the safe side. But pleural problems hardly ever occur. We very rarely have those calcified pleural residuals before operation. I think I see 1 or 2 patients with that every year only. So tuberculosis in Germany was no problem until 5 years ago. And now with a lot of people from the Middle East coming, it is becoming a real problem. Our tuberculosis stations are full, and it's also surgically becoming a problem again.
Okay. Is there any last question, or should we go to the next? No? Okay, let's give applause to Professor. Okay, before we have a lunch break, let's hear presentation from our resident, our fellow resident. Sorry, Prof, if we continue in Indonesia, is it okay? We will hear about diagnostic catheterization involving heart disease by Dr. Limax with opponent from Dr. Widya.